This is the sort of the speakers in the conference in Agaha. And this is my last, last time I was here. And you can see, I mean, we loved to, and this is me, of course. In 2009, I met Sumaira for the first time, and this was it was in Bangladesh, wasn't it? And I was, really impressed by this beautiful young lady. And then I had a mustache, and now 14 years after that, I have gone younger. I don't have a mustache. So now chronic regional pain syndrome was first mentioned by a guy, a German surgeon called Sudek, and he suggested signs and symptoms of reflex sympathetic dystrophy, and he thought that rightly that it was exaggerated inflammatory response to injury or operation on an extremity. And then the name was put for him, on him for the condition where there is bone loss with reflex sympathetic dystrophy. But there are so many synonyms for this condition. They still call, in some books and literature, call it causalgia, pseudic atrophy, post-traumatic dystrophy, still spark of shoulder-hand syndrome, algodystrophy, algoneurodystrophy, reflex neurovascular dystrophy, reflex sympathetic dystrophy. They all are synonyms actually for the same condition. I met this lady, Iqbal, who was 43 years old, and she fell on her outstretched hand and had a Colles fracture. And the fracture united actually quickly. It was just a simple simple fracture, which within 6 weeks she was better in terms of X-ray. But she continued with severely painful edema of the forearm and her hand. And actually, the first time she came into my office, she begged me to switch off the fan, because even the air of the fan was painful to her. And she was wrapping her hand with towel. So I thought this is one of my first cases of reflex sympathetic dystrophy, and I gave her prednisolone at the time, which was tapered over 3 weeks, and pregabalin at the time that was in the literature to be given for this condition. And actually, 1 month later, she felt better. The edema was less prominent. And then my second encounter was with a guy who had a road traffic accident previously, a soft tissue injury, but it didn't show any fracture. And he had paresthesia, swelling of the right hand, and pain in the right shoulder. And the right hand was hot, dusky colored, dull pain, and I thought that this is also a regional pain syndrome or reflexive dystrophy. Again, he was put on steroid, which was tapered gradually, and he was put this time on duloxetine, calcium, vitamin D, and pregabalin at night, because he was sleepless from the pain. Now, he continued with some pain in his right shoulder and pain in the hand, and I lost track of him. The third case was a patient who was diabetic, and he is Yahya, who was 65 years old, and he also had a fall and fractured his leg, but at the same time, 1 month later, there was severe pain, intolerable pain in the leg and foot, and even doesn't tolerate even to be touched. And there was swelling and hotness. And again, the same, almost the same therapy was given to him, elderly who was also put at the time on risedronate, but continued with the severe pain. Khulud, and again this was another lady, and she had also a fall, no fracture. She was put up, although there was no fracture, on POP and physiotherapy, but again, when she came to me, there was a severe limitation of movement of the elbow and the wrist, severe swelling of the wrist and hand, dark colored skin, definitely well different from her other hand. And again, this patient was given steroid, physiotherapy, duloxetine, calcium, vitamin D, and despite the treatment, she continued with the pain. So what's this condition that probably is shared by rheumatologists and maybe orthopods? And there is regional pain. It is a regional pain disorder that affects the distal extremity usually, following either fracture or soft tissue injury or surgery. And there are 10% of the cases, there is no history of any event that caused it. And the pain is regional, not confined to the distribution of specific nerve or dermatome. And the onset of the symptoms is in days or weeks after, or even months after the injury. The presentation can be quite dramatic, and the pain is disproportionate in time or degree to the event that happened. So some can have even trivial injury, and the pain can be really severe. It's easily missed. I mean, I'm sure all of you as rheumatologists, you face these conditions and you might miss them. And I thought this is a reminder of this condition. So please put it in the back of your mind when you meet somebody who really complains of severe edema and severe pain in usually the hands more than the lower limbs. So it's more in women than men, from 2:1 to up to 4:1, and its highest incidence is postmenopausal. So it might have something to do with the hormonal balance. And the most common inciting events, as I mentioned, are sprains, surgeries, crush injuries, falling without even a fracture, and recently they tried to subdivide it into CRPS1 and CRPS2, and CRPS1 is without nerve injury, and the old name for it, reflexive sympathetic dystrophy syndrome, and CRPS2, and this is when there is nerve injury present, and previously the old name was causalgia. As I mentioned, pain, sensory changes, motor impairment, autonomic dysfunction, so sweating, and trophic changes in the affected limb. The upper limbs are more commonly affected than the lower, and pain is the defining symptom. You could easily brush these people away, saying they are neurotic or they are exaggerating, but it's very painful. And they would complain of either burning, stinging, lancinating, it's like razors cutting their sort of skin, tearing sensation, which is felt deep inside the limb. They can have, as I mentioned, hyperalgesia. I mean, this lady who asked me, please shut off the fan because I cannot even tolerate the air touching my hand. Allodynia, abnormal feeling of pain, hypoesthesia, anesthesia dolorosa, and hyperpathia. And hyperalgesia is when there is increased response to stimulus, and hyperpathia, augmented response to any stimulus. The autonomic dysfunction is important to categorize this condition. There's abnormal asymmetric sweating and edema and vasomotor instability leading to altered skin color and temperature. So the temperature changes sometimes divided into cold CRPS and warm CRPS. There might be actually these conditions continuous. Atrophy actually can occur in the soft tissues, muscles, and bones can occur. There is actually criteria, the most used criteria, they call Budapest criteria for the diagnosis of CRPS. And the Budapest criteria is divided into two. One is concerned as symptoms, and the symptoms are the same list that I mentioned, and the signs also one sign in at least one of the two categories. Again, I did mention this. So in the differential diagnosis infection, of course, the first thing we will think about of the skin, muscle, joint, or bone, we will immediately think, oh, there may be the injury caused some sort of bug that has penetrated the skin. Peripheral vascular disease is another differential diagnosis, compartment syndrome, thoracic outlet syndrome, atypical rheumatoid arthritis can mimic, and Raynaud's phenomenon can be also the differential diagnosis. And I can assure you, personally, probably I met more patients with this condition than I really diagnosed, because in the back of my hand, I will think of all these conditions and I will not think about CRPS, which is a real entity that we need to care for. If we X-ray these patients, there will be subperiosteal and trabecular bone resorption in the affected part of limb. And so there is bone demineralization and osteoporosis. Bone scintigraphy is also useful, and there is increased blood flow and blood pool activity due to the hyperemia and delayed increase of the periarticular uptake in the small and large joints of the affected limb. And I would recommend, if it is available and within the budget of the patient, then to send these patients on scintigraphy. And it's always useful when both limbs are there. So even when you are doing X-ray, please X-ray both hands on the same limb in the same session, because this will really tell you that one hand is more rarefied, the bones are, there is rarefaction than the other normal hand. So you will find patchy bone osteoporosis involving the affected hand. There is no clear role for MRI or CT scan for the evaluation of this condition, and MRI may be useful to exclude other conditions if you are thinking of them. So probably the gold standards here in imaging are the scintigraphy and the X-ray. There might be genetic factors, and that's why we see injuries to so many people without developing this condition. And there has been sort of genetic association with HLA, 2 loci, DR15, and PQ1. In the treatment, cortisone and steroids, they inhibit the production of inflammatory mediators, reduce transcription rate of dorsal root ganglia, and reduce the SP content of sensory neurons, and they facilitate degradation of the neuropeptides. So steroids is always top in the list when we first meet these cases. There is also a role for sympathetic blocks if they can first try to see successful if there is successful pain reduction of more than 50%, then they can repeat injection of stellate ganglion and in the upper limb or lumbar sympathetic chain blocks. And these probably some of our either neurosurgeons and nowadays pain specialist doctors can help us with these. There is something, I never came across it in Iraq. I don't know if it's available in your country. The Demzo, which is dimethyl sulfoxide. And this is topical treatment. And it's supposed to be effective in reducing the hypoxia related to production of free oxygen radicals. It's not available for me, so I never used it. But the available ones are antidepressants. And these are also part of the treatment. Tricyclic antidepressants can be useful, and their analgesic effect is based on the serotonin noradrenaline reuptake inhibition, and they work on blockade of the sodium channel. The problem is with the side effects. Many of these patients, they tell you that they get either palpitation or increased somnolence if they are overdosed. The anti-epileptic category, pregabalin and gabapentin have role. They are calcium channel blocking agents, and they might be used efficiently in these patients. There is less convincing data about carbamazepine in these patients. Duloxetine, which is a combined serotonin noradrenaline reuptake inhibitor, has been found to have better results and less side effects than even the anti-epileptics. Opioids, studies on other types of neuropathic pain suggest opioids can be effective. Physiotherapy is also important. And the physiotherapy, interestingly, involves putting a mirror separating both limbs of the patient, and so he sees his good hand, and we tell him to move actually the hand, but actually what he does, because of the mirror, he is moving the affected side. So it's one way of convincing him to exercise the affected hand. It's a trick, but it is useful and has been found excellent way of forcing them to exercise the affected hand. TENS, the transcutaneous electric nerve stimulation, may be used also for these patients. However, the evidence comes from spinal cord stimulation, and there is no data for CRPS yet. So that's all for this condition. I must say that probably some people will think this is surgical, or why do they come? They will come to you. So please don't miss them. And management is equally better done by us. And really, you'll save these patients. And I can't emphasize enough the happiness of my patients whom I did treat them, whereas everybody brushed them away as being neurotic.